Today I want to talk about the ovarian cyst in pregnancy. So as I want to say, it's a benign. Most common is a benign condition. First is a pregnancy related the ovarian cyst. For example, it's a corpus luteum cyst, which produce progesterone to support the pregnancy during the first trimester, and then it will spontaneously regress by 8 weeks of gestational age, and the placenta will take over to produce the progesterone. Okay, surgical, when you remove the cyst, there is a lead to miscarriage. Okay, cystic is highly vascular and prone to spontaneous hemorrhage. There is a by ultrasound you can see ring of fire. About the follicular cyst, is a physiological matured follicles. Is the diameter is less than 2 cm. Because the follicle is a fail to involution and fail to mature follicle fail to rupture also. So it's a conservative management. It will regress about before 16-week pregnancy. The hemorrhagic cyst is a sudden abdominal pain. Patient maybe, if a stable patient, we may take as a conservative management. Usually it's a benign condition, and then it's difficult to distinguish from malignancy. But the hyperstimulated ovary is related with the induction ovulation. Alright, about the luteoma, it's a rare benign condition. It's a luteinized stroma. Cell replace the ovarian parenchyma, produce the androgen. The female will become virilization about 25 to 30%. And then there is a rule of there is a risk of female fetal become virilization also. So about the benign condition, the most common is a matured cystic teratoma, what we call is a dermoid. Most common is a less than 6 cm or equal to 6 cm is asymptomatic actually. More than 6 cm are prone to torsion. The risk about 27%. Okay. So another condition is a malignant condition. It's a dysgeminoma, but it's a common among the germ malignant tumor. Okay. Alright. Others is okay. So differential diagnosis, as I mentioned before. So for an SMS, there is a differential diagnosis between gynae and non-gynae cause. Gynae cause like I mentioned before, and then non-gynae cause is appendicular mass, mesenteric cyst, and diverticular mass. Alright, but the others like sex cord tumor is a rare present. Right, about the symptom wise, you must ask about any acute abdominal pain symptoms like torsion, rupture, and hemorrhage, or any abdominal distension, urinary symptom, and constipation symptom. About the previous gynae history also important. There is a mass before pregnant and ovulation induction also. So per abdomen, you may palpate the abdominal mass, and VE you may palpate the adenosine mass also. About the scan, we did the scan, and then we can see the ultrasound scan to detect any imagings that suggest feature of malignancy or benign. Alright, so the color Doppler improve the scan finding also. So right, if you plan for surgical intervention in the stable patient, so I may suggest for MRI. It's more safe in pregnancy, and then it's useful to suspect malignancy case, and better tissue composition and characteristic and fat. So the issue is expensive, not widely available, and prefer MRI. So because the CT scan has a radiation exposure. About the tumor marker, CA125 is a risk over 80% of female with the epithelial ovarian CA. However, there is a difficult to interpret during the pregnancy, because during the pregnancy, the first trimester they will peak. So some author they take the cut-off point CA125 is about 112 for pregnancy. Alright. Okay. Number 2, LDH. In this dysgeminoma, LDH will increase, but the pregnancy not alter the level of LDH. Number 3, alpha fetoprotein SHG. So in pregnant, in the germ cell tumor, it will increase, but it limited usage in the pregnant woman, because also it associated with the anomaly during the pregnancy also. Okay, HE4 is a human epididymis 4. So they increase sensitivity in the ovarian CA, especially in the epithelium types of CA. It's a more sensitive and specificity compared to CA125. Others tumor marker like inhibin is a granulosa cell tumor and then produced in developing placenta also, so it difficult to translate during the pregnancy also. Alright, MI score is useful for non-pregnant women, but it's not useful limited usage in pregnant women. Iota score is a by ultrasound, its sensitivity about 95%, specificity about 91%. It's useful for to refer the gynae oncology. Right, Roma score is including of HE4 and CA125. Roma is a risk of ovarian malignancy algorithms. Okay, in the management itself is a conservative management, because most of 76% is a simple cyst less than 5 cm, and it's a functional cyst also, and spontaneously regress after 16 weeks pregnancy. Follow up is required for large cyst at around 14 to 16 weeks. Intervention, actually, if you plan to intervene, is at least you delay until 14 to 16 weeks, because to allow spontaneous resolution of the functional cyst and prevent the urgency on luteal cyst, surgery on luteal cyst. Right, in the benign condition, it can be managed conservatively, actually, if asymptomatic, aware of risk of ovarian torsion in pregnancy. Patient decision is important between risk and intervention, the conservative management and conservative management. Surgery is indicated in the case of acute abdominal mass, acute abdominal pain, mass suspicious for malignancy, rapid growing mass more than 20%, higher risk of malignancy, cyst more than 10 cm, cause obstruction of labor. So the adrenal torsion is an incident is about 1 to 5 in 10,000, pregnancy up to 16% in the, and then the pregnancy in the OHS is up to 16%. It's more common in the first and early trimester. They may present with acute abdominal pain, nausea and vomiting. The total weight will increase. CRP also increase because of tissue injury, and start raise after 6 to 8 hours of tissue injury. So the ultrasound can aid to identify is it the mass is the thickened and endometrious capsule, or the avascular center. Surgery aim is to distortion of the ovary and then to reduce the size of ovarian cyst to prevent the torsion and recurrence. Right. So if necrosis is a salpingo-oophorectomy. If you suspect any malignancy, it suggests for MDT approach. Consider patient age, gestation, parity, and desired fertility, and the stage of the disease is also important. So during the first trimester, risk of miscarriage is present, and TOP is in advanced stage. So during second and third trimester, we plan for cesarean section during the cesarean section, and if planned for debulking surgery together with the cesarean section. Alright, primary surgery can be limited to salpingo-oophorectomy and surgical staging. So in terms of surgical, laparoscopic actually is safe, less blood loss, and improve the visualization of pelvic organ, but and reduce risk of uterine irritability. The risk of CO2 is can also increase, and then fetal acid base disturbance and reduce risk of uterine blood flow, and reduce the placenta blood flow. Alright. Okay. The potential risk of injury to uterus during the insertion of primary fort. So we advise to do the Hassan technique or palmar entry may consider when surgery is performed at second trimester. So actually laparotomy is preferable compared to the laparoscopic, because it's to minimize the advent cyst, rupture, tumor, and cell dissemination and port site metastasis. And if malignancy is suspected during the first trimester, suprapubic transverse or lower midline can approach, and during second trimester is a midline skin incision. Alright, during third trimester we plan for hysterectomy, scissor and laparotomy. The conclusion, the principal goal of assessment of diagnosis are to diagnose accurately the adnexal torsion or malignant are important to determine intervention and